All right. Hello. My name is Matt Griffo, and I am with Matt Bodett. And today is
April 22nd.
April 22nd, 2026. And we're going to be reviewing some questions that people had for Matt Bodett. And we're going to be reviewing uh, I suppose, some of the theology of mental health, I suppose, in that way. So let's start with the questions. So the first question is from Mora, and she says, he said he learned to identify the bottom ring of the psychotic ladder, which was anxiety. How did he work with his anxiety at that point? He said he did not use medication, but what did he do?
All right.
Yeah.
So again, as I guess a preface to that, is an understanding that what worked for me won't work for everybody. So what I'm offering is really just a way of understanding that there are ways through it, and for each individual, that path is going to be considerably different in how they navigate it. But there were a range of things. If I think down to that, what is sort of the first experience that I can physically understand in my body, and it was anxiety kind of is that baseline. So I know if I can handle and work with the anxiety, I'm less likely to feel some of the bigger kind of symptoms that really affect and become outwardly very visible. So anxiety for me, I began managing it in a lot of different ways, some of which included I would not have used this language at the time. I have come to understand it as meditation. At the time, meditation was not a practice of mine. I didn't see it as a daily part of my life. I didn't understand it. So that would not have been language I used at the time. So what I thought I was doing was sitting and more or less doing what they do in a lot of like yoga and meditation is like body scan. And recognizing where am I actually feeling this, and at some level can I in my attention to it, can I breathe compassion to it,
To it being,
whatever part of my body I'm feeling that anxiety.
oh, okay.
Can I actually just give it oxygen and breathe to it?
Yeah.
And for minor things that would be helpful. So there was a level at which sitting with it, acknowledging it, being with it, could calm and be present.
Yeah.
Which is actually developed into, we can talk about this for other things as well. We can put it on our notes.
Okay.
Is a practice that I do. So when I work with folks at the Center for Mad Culture,
I'll make a note.
one of the kind of workshops that I run with people is called Breakfast with My Voices.
Okay.
Which is this idea of being present, acknowledging, and offering compassion
Yeah.
to something. In this example we're talking about is anxiety. In the workshop, it's more things like voices and hallucinations.
Sure.
So that's one ground of it. There were other things where I started to recognize patterns in my life that would help it, help to alleviate. For example, I learned at that time in my life, I needed at least 9 hours of sleep. Minimum. And so I would often sleep a lot more than that. And that became very instrumental, which was hard because I was also in school. In school, I mean, you do late nights studying, and then you're up early for the test.
Right.
Whatever it is. And so this,
How old were you at this point?
I would have been in my mid-20s.
Okay. So you were figuring this out on your own.
Oh, yeah.
Yeah.
Yeah, totally alone.
And at that point, were you on medication at the time, or is that the point where you had decided I can't handle being in this low functioning state on the meds. So you were
I was cutting the meds.
you were
So I had cut the meds and realized,
was it a slow or
oh no, I cold turkeyed, and which was dangerous.
yeah.
Um, um, yeah, if folks are like listening and they're worried about like don't go cold turkey, there are multiple books. There's like the harm reduction guide to coming off of psychiatric medication, which was put out I think by Fireweed Collective. Um, there's a couple others. If people wanted to reach out, I have resources
Mhm.
that are like how do you come down off of psychiatric meds because they're miserable, and it took me years to really fully come off of them. So this was that time where I had come out of a hospital. Um, they had cut me from my old regiment, given me a new one, and I knew before the new one settled in, I had to cut it so it didn't elongate. So I did that, but then I was also still around a lot of people who held very rigidly to I need to be on medicine, I need to be doing these things, and it was like coercively told, you can't, you won't get better. There's no treatment. You have to do this. I knew I was in that system, so I had to present like I was doing well.
Oh.
So part of it is I was coming up with this regiment for myself and being attentive as a mask,
Mm.
as a self-preservation,
Yeah.
because too many people demanded that I be on medicine, and it was the point at which it was just destroying everything that I felt like I was.
When you say too many people were demanding you be on medicine, can you expand on that part?
Well, there's a whole anytime you get into the mental health system, it's like teams of people you have to interact with.
Ah.
So it'll be family members, it'll be possibly friends, but then there's going to be counselors, psychosocial rehab workers, psychiatrists or psychologists, like a mental health team.
And so,
So it's like all of these people together,
Mhm.
they act more or less as one mind. And
Mm.
so if the doctor demands you are medically compliant, everybody tells you you have to be in order to receive services. And so everything is off the table. So if I were to, in that circumstance, if I was to go off medicine, they would cut all my services
Oh.
because I'm no longer medically compliant and they don't want the risk of me
Ah.
doing something while non-medically compliant,
Right.
without understanding that my best self is off medicine. And
For you personally.
yeah,
Yeah.
yeah, like for me, that was the route I needed
Yeah.
to be healthy. And if nobody's gonna join me on that sort of like health journey, it's gonna be miserable. It's gonna be extraordinarily painful.
Right.
Which again is sort of like the where I'm at in my life now with like the Center for Med Culture is, can we offer alternatives so that people who choose a different route at least have people who can guide them and be with them and not abandon them.
Alternatives to
A medical system. So if somebody is going to take a similar path to my own,
okay.
and they say I don't want the medicine, I need to do kind of what the question's asking. I need to understand anxiety at that level.
Yeah.
What are the practices? Who can I talk to?
Mm.
We want to offer a place where people can talk honestly about that
Mm-hmm.
and decide what is going to be the best thing for them without abandoning them. When we abandon them, we isolate them. It reduces any chance at hope. They again feel victim to systems that tell them that they're not worth care unless they follow a very specific path.
Mm-hmm.
And our belief is everybody's worth care, everybody's worth compassion. Even if you don't choose to be on medicine, there's going to be a way through it that is going to be healthier and less destructive.
Mm.
So, what does it take to listen to you? What does it take to actually care at a level that most people don't? The other catch rate is we get into the mental health system, and a majority of contemporary, this has to do with, I mean, you kind of brought this up off camera, some of the economics of mental health and madness.
Mm-hmm.
It is very common for a lot of emerging mental health practices to focus specifically on early intervention because that is the highest recovery rate. It is difficult to work with, I'm using
Sure.
air quotes for sure. It is difficult to work with folks who have been non-medically compliant or older. So if you can catch somebody in the first, I think they say 6 weeks of their earliest symptoms, they quote unquote have a better prognosis of healing. So you'll find that most mental health services aim towards those because they can get better grant money because they have higher recovery rates.
Oh, okay.
So it has to do with financial resources,
Oh,
which then means that they leave the people who are in most need of services off the table because they're the non-medically compliant. They're the ones who are possibly so agitated they're yelling, and they're not understanding why the yelling is occurring. They don't want it around them. So those are the people who end up kind of outside the system with no place to go because the system only wants compliance. So that, I mean, this is a whole like roundabout way of still getting to this question. So it's really now down to, for me at least, that's not the system I want to be in. I don't want to be in this coercively. And so it began with meditations, understanding my sleep. There were things like I would, for all outward appearances, it would appear like I was maybe acting more crazy.
Okay.
I would build myself a little fort.
Yeah.
And I would hide in the fort, and I would isolate.
When you say a fort, because I used to also do this, I'm really confused. I'm so curious. What is the little fort? This for you.
In one room I had, I would move my desk and my bed into a corner, and so I would have to climb over my bed to get into the floor, and then I would sleep on the floor, and like I'd build like basically a little cave for myself.
I had like sheets and stuff, and I like used pins, and I would like go to that area.
And
I would just like study or something.
Yeah, I mean, I'd be reading very often. For me, putting on music was a very helpful thing for my mind.
Yeah.
It got me out of the process of language, the vocality of language.
Yeah.
It moved me into a premise in which language no longer mattered, and I could ease.
It's interesting. As I was writing, if I'm writing something or working on or creating something, maybe I was doing sculptures when I was a kid. I would like clay, the colored clay that I would bake, but I would listen to like Mozart and Bach, and it's great.
I was a Beethoven Rachmaninoff person. I'm more of the tortured.
Oh, okay.
Get me into the pain of it.
Mine was like yeah, that's really funny.
Or do you know Glenn Gould?
Yeah.
Glenn Gould was another that I would listen to a lot. But we're talking like there's something about the tortured music.
Yeah.
That still felt very
he
resonant.
Was clearly tortured. I mean, you listen to Glenn Gould's music, and he's like.
You can hear him, yeah.
And I'm thinking to myself, what's going on with buddy? Glenn, are you okay? He was not okay. He was really Bach really drove him into a state of extreme focus.
There was a funny story. This is totally going off on a tangent. Who's the super famous conductor?
I don't know conductors as well.
Anyway, he had very illustrious career, very well known, and he got up before a performance, and he's like, I don't do this, but I need to give a preface to this performance. This is not my MO, so I don't do this, but I just need people to know that the creative decisions made here are not mine, because usually he has a lot more control. And he said, I need you to know that they're not mine, and I need you to know that I've only ever once worked with an artist so difficult. And the first time was with Glenn Gould, and this time it is Glenn Gould.
Oh my gosh.
And he just like outright says, this is the hardest artist I've ever had to work with, because he was mad. He was a mad human, and he understood music in his own way, which I think in part resonated a little with me.
Really?
And I didn't know all those stories maybe as young as I was. I just knew. And actually I had just seen too, because I got into his music, and he has a radio drama called The Idea of North, which is beautiful. and then he did. There's a film, 32 short films about Glenn Gould,
Mm-hmm.
and I watched that and thought, oh my god, this is me. This resonates so well.
That's wild.
So I think there was something about him and his temperament and his music that comforted me,
Mm-hmm.
and I found myself being mirrored in the musical language,
Mm-hmm.
and I didn't feel quite so alone.
That's really nice.
And
Yeah.
it was as much as people think it's tortured, for me it was absolute comfort.
Hmm. Well, so going back to we were talking about what was it we were talking about? What was the what
The
were
question was the anxiety and what I was doing to get through the anxiety.
Mm-hmm.
So I'd build these forts.
Yep.
Music was a big part of it.
Mm-hmm.
Um, I'm an isolator, and I've learned that isolation is not a bad thing.
Mm-hmm.
It's often listed as a negative symptom for folks, but for me, it was that's where I regenerate.
Now, when you say isolation, because some people are isolating and they're not around anybody for a year,
Yeah.
that's different. You're considering isolating it as in you're taking a few days or maybe some hours of alone time. Where right? Is that what that is?
Which diagnostically could still fall under isolating if it interrupts daily life.
Oh, but you were
But
just
I'm not talking years of
Yeah.
alone. I mean, weeks at most of
Yeah.
just being alone. I also found, though, there's an aloneness that I can appreciate where I'm in a big city now,
Mm-hmm.
and I can be alone because I don't know anybody.
Mm-hmm.
I'm around people.
I'll go out and just take I'll take photos around the city, or I'll just I don't know, do something. But I
So I can still be alone.
Mm-hmm.
So isolation does not always, for me, represent the cave.
Yeah, I think that's a good differentiation between those types, because then you do have some people who are, when they're doing what they would be considered, maybe they didn't even consider it isolating, but they're. I think part of it is that you're considering it isolating, and some other people might just they're not around anybody for again a year, and they're actively worried or anxious about being around people or going out to a store. I think that's a different thing.
It's a different type of isolation that would, I mean, yeah, it still has to be like talked through and
Yeah.
figured out the nuance. Even now, I don't build caves anymore. Maybe I should.
Same.
But I have what is near a cave in my house now.
Okay.
I have a specific chair, and it's in a corner of a room. I have a table that I can work at. It's just short. It's not a full like 6 foot or anything. It comes out one way, and then the bed on the other side. So it is almost the cave.
Yeah.
But at a level at which I can still find comfort.
Yeah.
That's if I'm in as early sort of state.
Yeah.
I'll just toss on headphones and I'll go sit and read in my corner.
Yeah.
And that's one of the things that I need to do.
Mm-hmm.
And then the other is just going back to the other things, sleep. I'll just make sure if that is going to occur, that I probably cancel whatever I have in the morning. If it's going to be a class or work, I just let them know either I'm going to be late, what do I need to do, and I'm going to sleep through it.
Did you start in your mid-20s? Did you start making a bedtime routine almost, or no?
Mm-mm.
Or did you just stay up as late as you could until you pass out, type of thing?
No, I never had I was not somebody that had trouble sleeping.
Oh, okay.
I could sleep at any point.
Oh.
So I would just I would be, and especially as an artist, I tended to work more in the night.
Yeah.
That was my temperament is a night
Mm-hmm.
person. If I had my own schedule, if I was completely financially secure,
Mhm.
and I could choose my own schedule,
Mhm.
I'd be in bed midnight 1
Mhm.
o'clock, and then I'd be up and slow moving for the morning, and I wouldn't be active until probably 1 or 2 in the afternoon.
Right.
And then I'd be full on engaged with the day.
Mm-hmm.
So my day would exist sort of on that realm, the 12 hours between like 1 and 1.
Mm-hmm.
But so as an artist, I would tend to be an evening, and then I never had problems sleeping.
Yeah.
So I would just crash. Now I have a harder time sleeping, so I'll take some sleep aids. Just if it's typically not up front, I'd avoid any medicine as much as possible.
Mm-hmm.
But if I go a couple days where I'm like
When you say a sleep aid, what are you taking?
I'll take edibles. So
So
I'm
CBD or THC or something?
THC.
Oh,
Yeah,
okay. That's your sleep aid?
that's my sleep aid.
That makes sense. Okay. But not melatonin or
Melatonin ruins me.
oh, have you ever? But so you may be taking too much, or you can take none at all. But some people, like for example, some people 10 is where I'm at for 10 milligrams. But for some people, that's way too much, and they should actually be taking 2.5 because they're more melatonin sensitive,
Hmm.
which is probably why you would be a good sleeper, is because your system may actually be, we can't know that without tests, but your system may be just more sensitive to melatonin, which if you were to give melatonin to a cat because they're nocturnal, the cat's actually going to feel more awake. It just says when it's daytime and nighttime, and so what we're supposed to do is we're supposed to see, supposed to as in uh, daytime mammals, we're supposed to see the sun in the morning, and it registers in our brain it is daytime, and then however many hours later, as the sun's setting and things are getting darker, it signals to our body to increase melatonin production, and then a person gets sleepy. So I need a higher dose probably because I'm not so melatonin sensitive, whereas you may be more melatonin sensitive. So potentially you could, if you did have melatonin, you could just cut it down to a 2.5.
And for me, it's I think it's even more than melatonin. Any medicine I take, I'm hypersensitive.
Ah, yeah,
So that's why I also try to stay away from
it's
most
understandable.
pharmaceuticals.
Yeah,
Is that whatever it is about them, my body just
I get almost every side effect when I
fully
take something. Like
kicks me.
almost everyone on the list. I'm like, oh, okay, okay, all of it, and some other ones that are on here. Go. Okay. The other question is, what else did he do to taper off? He must have been aware, and his thoughts on anosognosia.
So the tapering off, I think we answered. I didn't taper.
You did not,
Um,
which is dangerous, very dangerous.
if you're unaware, the dangers are extreme withdrawal symptoms,
Mm-hmm.
which I actually do feel like I probably experienced. What we don't understand too is that a lot of the symptoms that we think people are acting under as like psychotic symptoms tend to be withdrawal symptoms.
Right.
So what we're actually seeing when we see people in psychosis is actually going through a withdrawal of the psychiatric medicine.
Mm-hmm.
So their actions are more about withdrawal rather than a symptomology or a medicine.
Mm-hmm.
They're in that in-between state. And so we tend to see people more agitated, more aggressive, or withdrawn and lethargic.
Mm-hmm.
Even some of the side effects will rear up, where it can be speech impediment kind of stuff, or they're slurring. So you'll get a lot of that kind of stuff occurring.
Let's just hypothetically say that we had a healthy control subject. Healthy control subject for clinical data is going to mean that they're falling within standardized blood metrics. So they're not too low, they're not too high. They're in what current science is considered the healthy averages, which actually those averages for Olympians, for example, they are not within those averages. They're actually so beyond them. Their resting heart rate tends to be it's much below the standard level. They have bradycardia, which would be considered bad for a person who's not in fitness, but it's actually good for them. So they maybe have, like, my resting heart rate's 45. That's actually really bad because the lowest number it should be is 60, but that's a should. But I work out a lot. If I get stressed, it swings up to 50. When I'm sleeping, I can get down to 39 or 38. But that's because I have a strong cardiovascular system. But we take a healthy control subject, okay? And let's give them, hypothetically in this situation, an antipsychotic, just whichever one. And we could take a classic one because that's the ones that are studied the most. Basically, all of them over time are going to cause a decrease in gray matter, which is how our neurons fire and function in the first place. It's going to cause damage to the basal ganglia, and it's going to cause demyelination. So the basal ganglia is a part that controls motor coordination. So they would have a high likelihood after a few years of developing different tics, and they would have lower speed. They would have if they were doing speed tests for movement speed tests, they would be slower after some years. So that would be a person who was previously healthy. That would just be the side effects of what would happen to a healthy control subject on those medications. And then a person would then think that they have problems simply because of the side effects. So you're absolutely right that in this hypothetical scenario, if you did that to somebody, well, they're going to get these issues over time.
Mm-hmm. And then we use those issues as proof of the diagnosis.
Right.
After the fact.
Right.
And so typically when somebody enters into the mental health system and starts to go on and off medicine, what they're doing is they're adding and crashing.
Mm-hmm.
So they're increasing their symptoms because there's side effect symptoms.
Right.
They don't like the side effect symptoms, so they go off and then they crash, which is going through withdrawal symptoms.
Right.
So we're moving through two extremes of psychiatric kind of pharmaceutically related symptoms.
Right.
And then we're assuming that those symptoms on both ends are evidence of the underlying diagnosis.
Right.
Which can be deeply problematic
Mm-hmm.
when the experience of those symptoms does not line up with what's occurring on the
right.
other end.
And I want to reiterate that for each individual, we are all unique. It doesn't mean that medications are wrong for everybody. I personally get almost every side effect symptom whenever I take anything, even something basic. I've never taken anything like that, but I am pretty positive based on my other results I've gotten from other things. I would probably not do so good on them, but I'm me, and I know that about myself, or at least I know that I'm sensitive to medications, and so I think everybody's different, so they want to decide for themselves on what to do. But the medications do exist for a reason. They are helpful dependent on the individual's needs and desires and what they want to do with their own body, I think.
And I guess that brings up the anosognosia.
If we know how to say it.
Anosognosia. Anosognosia.
Anosognosia. Anosognosia. Okay, so what is anosognosia? Anosognosia is a condition in which a person is unaware of their cognitive decline, most often seen in Alzheimer's disease or other causes of dementia. This lack of awareness is often confused with denial and poses unique challenges for care. So, there you go.
And it's a little different with something like Alzheimer's, where the whole symptomology of that is like a memory decline.
Yeah.
Somebody could quite literally be unaware of their own decline.
Well, I think this word is getting...
It gets blown.
I think it's getting broadened.
It's very broad, and I think that's the point I want to bring up.
From where it began, it's become a broader spectrum of what that would be.
And so now we've broadened it to just illnesses.
Mm-hmm.
So now, if you look up other definitions, we'll also include in that definition a condition in which a person is unaware of their illness.
Yeah.
So now we're talking like big picture mental health kind of illness.
Yeah.
And this is where I think it gets tossed around very frequently, is to just say that if I tell somebody, if my child is exhibiting what I see as symptoms, and I go and I talk to my doctor, and I say, "Doctor, I've got to help. My son Matt is experiencing hallucinations, visions, hearing voices, and those are all things that I'm secondhand reporting, right? Typically, it's not. It'll be kind of that way around. if I'm the parent, of course. And I tell the doctor these, and the doctor says, "Oh, this is like textbook schizophrenia. Um, I think your child may have schizophrenia." And then I go back to my child and I say, "I think we figured it out. We can get you help."
Oh,
Oh,
I'll be.
we're
I'll
gonna
be
role
chatting.
play.
Okay.
Whereas, like, I figured it out. I know how to get you help.
Okay. I don't need help, but go on.
And then I would just explain, right? I talked to doctor. I explained the things that you were going through. I told him about your visions and the hearing voices, and he agrees with me that you have schizophrenia.
This is where I throw a chair. I don't have schizophrenia.
Now, I think a lot of parents would understand this dynamic, and they would say that the child is wrong to go through this sort of frustration. And that would be the point at which anosognosia is employed to say, we know, doctor and parent, know that you're going through something, and in this moment you're unaware of it. So now we can diagnose you with this anosognosia, and that clinically gives us the power to either take over your medical autonomy. We could legally step in as a guardian and do the guardianship thing. Or we could have you institutionalized against your will. Similar to the guardianship, but maybe less legal in terms of like bigger picture. But either way, the child loses all autonomy.
Mm-hmm.
Choices are then forced upon child
Mm-hmm.
because they have anosognosia.
Now, there are some instances where you have somebody who's saying, I'm talking to God, the God talks to me through the trees, and so every time I know that that's a fact because this is what they're saying. This is a made up scenario, but I know that it's God who's talking to me through the trees because there's no other way that that's possible. So I just know it to be true. And then the person says, "Okay, honey, you have schizophrenia. We need to put you on meds." And then they go, "I'm not being put on meds because I don't have that." Like, what do you like?
This conversation is all nuanced.
Mm-hmm.
So there's going to be many facets to this discussion. But if we just kind of run with this little, I hear voices. I think it's God speaking through trees. And I say, no, you need medicine. What's to say they're not hearing the voice of God through trees?
Mm-hmm.
And I don't mean this as we have to believe every delusion that somebody may be presenting, but it doesn't mean that we have to disbelieve it. And the caution here is if you tell somebody that they are not hearing the voice of God through tree,
Okay.
they're going to be like, but you go to church on Sundays and think you hear the voice of God.
I see.
Because it's a house of worship, it's okay that it's God.
Sure.
And because it's a tree, it's not okay.
Yeah.
So the reality of the situation can be considered, and this is where nuance comes in, right? Like every scenario is going to be a little bit different. So this is all hypotheticals. So what we're doing in this situation is we're saying that the dynamic between you hearing voices of God and me hearing voices of God are different.
Mm.
Because my way of hearing them is appropriate and okay. Your way is not.
Mm-hmm.
And what that's going to start to do is create a schism between the sort of power dynamics that start to occur in all of these decision-making scenarios. And if we create an unequal position of power, we keep using the child in this case,
Mm-hmm.
the person experiencing the voices of God, is very quickly going to learn to distrust anybody around them.
For sure.
Which we tend to think, of course, they're distrusting everybody around them. They're sick.
I'm not going to tell them nothing at that point.
That becomes a symptom.
Yeah.
Then, and it falls under the anosognosia thing, where they don't even realize they're sick because they're not even talking about it.
Yeah.
No, they just don't trust because they are saying that my experiences in the world are just as valid as yours, and you keep telling me that they're not valid. And parents might say, I'm not disvalidating it. I'm trying to validate you, but get you help. getting help is an assumption that your experience is not natural and appropriate.
Mm-hmm.
So there is already in the assumption that somebody needs help a dislocation around the experience being authentic.
And now just looking at language, a lot of the terms I'm using the language of clinical science, and I'm using that language because I was brought up on it, but also I feel that that's the fastest way for me to relay and have a linear understanding of a baseline of what we're talking about, because that's how we can get what's in our mind to another person's mind is in part language. So I'm using that clinical language. So anosognosia at the as a neurological and psychiatric condition where a person is unaware or denies their own illness or disability stemming from brain dysfunction rather than willful denial. And again, we're looking at it's common. It says here common for Alzheimer's, schizophrenia, bipolar disorder following a stroke. Key symptoms include extreme denial of impairments, arguing against diagnosis, and refusing treatment. So now let's go within language. So we have that term, anosognosia. Now, if you're just looking at how to help somebody, I want to help human A. And human A doesn't agree with that
With schizophrenia.
with that language.
Yeah.
That term, whatever term it is, regardless of if it's Alzheimer's or schizophrenia or bippity doo dah day. I don't care what it's called, but whatever it is, if it's heightening them and making them feel worse, that doesn't seem very helpful in general. So to me, when people say to me, I have, or this person has blank, regardless of what the thing is, and I don't think I have it, and they don't think they have it, whichever way it is, what do you think? I kind of don't care, because there's overlap for everything. If you understand the biomechanics of the body and how that interacts with the mind well enough, you already know that there's overlap for all of them. And they just, the symptomologies come out in different ways because there's different abundances of different microbes or different blood levels or different genetic factors that are all being turned on and off. And it's so complex. But regardless, there's overlap for all of it. So at any given time, if somebody has one diagnosis, well, they're going to normally be able to have probably a bunch of other ones. And depending on what clinician you're going to talk to, they may diagnose it with something else or have additional ones, or it may change a year later. So to me, the language is important to be able to quickly identify what symptomologies we're speaking about. But if that's not helping the individual, I don't care about the terms in that regard. I know them well enough, but that doesn't, even though I know them well enough, it doesn't mean I'm going to use them all the time. I'm going to actually then say, what symptoms do you have? And then they could say, I don't have any symptoms. Okay. How do you feel? Well, I feel upset. Okay. About what? Then they would talk about it. I feel upset about this. And then maybe through that discussion, 2 days later, they might say, actually, I'm having this weird skin thing happening. Or I'm having actually this pain in my tummy. Because suddenly they've opened up and they're not as intimidated to share because you suddenly listened and you didn't scare them off. Because you're already dealing with somebody who doesn't want to talk about that. Generally, whatever it may be, or let's take somebody who has Alzheimer's or dementia. You're looking at a person who, whatever level they're at, it's not just that their mind is unwell. You're looking at usually glucose problems. You're looking at metabolic dysfunction. You're looking at way too many pathogenic microbiota that are inside of not just their gut, but it could be toe fungus. It could be, they're getting thrush in their mouth. There's so many different problems that could be overlapping, and everyone is going to be different. But regardless, if you say to that person, you have Alzheimer's, and they say, shut your fucking mouth, you're a dirty little turtle. You know that you're not a turtle, and you know that they previously, 10 years ago, never used any foul language like that. But here they are. Here's grandma being real sassy. At the bottom line, what would help grandma feel better? What would help X person feel better? And that's also going to have overlap. That's going to be what's going to increase their metabolic rate. That's going to be what's going to help them decrease in inflammation. How can they get better sleep? How can they move their body? How can they get out into the sunshine? How can they balance all these different systems? Look at their overall organ systems and how that can balance. And just listen to them. Because regardless of what it's called, they know something's happening. I was asked about that for myself, anosognosia, and if there was somebody who could talk about it, or if you could talk about it, and I said, well, I by definition terms, I would have had it.
Mm-hmm.
I mean, as a kid, I was studying mental illness, but I wouldn't have thought that I had. I understand all these symptoms are gone, by the way, but I understood that there were these different mental illness, what were considered different mental illness symptoms. And again, I'm using clinical language, right? But I didn't think that the shadow demons that were following me around were in any way fake. I just thought they were quite scary and annoying. And that I had to just kind of not notice them and really study really hard so that they wouldn't get more extreme about it, because sometimes they get a little aggressive. But that there was not one point in the entire time that I was looking at goblins or vampires or shadow demon creatures or red eyes in the trees. Like, there's no point. I'm on the bus and things are coming out of windows. There's no point where I thought that's a hallucination. 0 times did I think that. I didn't think that until they were gone. And it wasn't even like immediately after, because it was kind of a slow process. I actually just didn't, it was eventually, I was like, oh, wait a second, they're gone? I kind of missed them. I was like, where'd that go? And years later was when I went, oh, those must have been hallucinations. That was my end equation, was that. But as far as, if somebody said, and I did say to people, I'm seeing X things and blah, blah, blah. I'm seeing a different dimension. I was joking so often that they just thought I was joking, which is kind of good. I'm kind of glad that they thought I was joking, because I probably would have been put on antipsychotics or something. And I don't know what would have happened. But, for me, I just dealt with it. I would see these things. I would just kind of keep it to myself, because so often if I mentioned it to somebody, they would laugh it off and think I was being funny, and that's it. And so I just dealt with it until I had, and again, this whole time since I was a kid, I was working on different ways to relieve, and this is kind of where it goes back to just listening to somebody. I was trying to relieve multiple problems that weren't that. I was trying to relieve the kidney stones that I was getting since I was like 11 and 13 and up. Like, it was horrible. I was trying to relieve the sores that I was getting in my mouth all the time. I mean, it hurt. I haven't had them in, I don't even know how many years. It's been a really long time. I was trying to get rid of the pain that I'd have. I would get really bad Charlie horses. My muscles would cramp up really bad all the time. Even just sitting down in class, I would just get, in high school, I would get really bad cramps. I wouldn't tell anybody about it, because every time I did, when I was a preteen, it didn't help. The doctor didn't know what to say. So I would go to the library and study to try and figure it out. And eventually in 2010, you're looking at a timeline of, getting those symptoms at about 2001. and then relieving them, right? Wait, no, 1996. Holy cow, I'm old. So 1996, oh boy. And then relieving those symptoms, well, just the hallucination parts, but in 2010. And then I kept working toward relieving all these other symptoms. But at no point during that process did I think I need to not have the demon creatures around. I mean, they were like annoying, but I just thought I had a special gift that I could see them and that was it. Like, this is the rest of my life. I just got to get used to it. And I did. Um, the point, though, is that if somebody had said to me, what would relieve, because I was going to doctors, what would relieve all these other issues that I had said before, the kidney stones and the sores, and if those had been actually relieved, it would have decreased so much inflammation inside of me that those other things downstream would have also decreased. So again, regardless of what the title is, you can call it whatever you want to yourself, but if it's stressing that person out every single time you say they've got this thing and they're not agreeing with it, give it up. Just help them. If you want to, if a decade later you want to say with them, hey, do you ever eventually agree that you had schizophrenia? And then they go, yeah, and you go, oh, okay, cool. But if they don't ever think that, also cool. Is the bottom line is, what can bring them to better wellness at a base rate?
A big part of it is the listening part and being willing to, there'll probably be some upset parents. Or not going to be thrilled that I say this. But more often than not, one of the questions I will have to ask is, in challenging the person to take medication, to not take, whatever you're trying to get them to do, the question that I find most interesting is, whose comfort are you securing in that? Very often the parent is trying to comfort their anxiety by forcing the medicine into the in this case, the child. The same would happen on the street. If I see somebody who's acting aberrant and I'm like, oh, they need to get help. In that assumption, whose comfort am I protecting? Am I actually making life better for the person or for me? And so that'll be a question for parents very often is, whose comfort are you really seeking? If you're listening to your child, and I don't know why it is like we keep going to the parent dynamic, but I think we understand that it could be a friend, it could be
anybody.
It could be anybody. We're just using that.
I mean, my parents were out of the picture. Like, they were not. I was not talking to them about any of this. So it was, for me, it was always friends.
Yeah. So that relationship can be anywhere.
Yeah.
Even though we keep saying parent-child. So the question is, if you're only seeking your comfort, back away. You're not doing any good making it about you.
Right.
That is the least helpful thing. If that's the case, figure out what needs to happen. If you are genuinely after the comfort of the person, you're not asking them, you're not forcing them into a position of demanding care. You're going to pause and listen to what are the things that are you finding harmful to yourself right now, and how do we work through that? The answer is not always medication. The answers might be, you need housing. You need security in your life so you can actually start to address other things.
Yeah.
For some people, it's housing. For some people, it's food. For some people, it is, I need to decrease the sort of academic stressors. And you may need to figure something out through an IEP or something. For others, it might just be, I need somebody to just listen to me.
Right.
In which case, a talk therapy and finding a therapist who might be more aligned with like a MAD paradigm could be totally fascinating, where they're not going to force you into medical perspectives. They're just there to actually encompass like a kind of like true lineage psychotherapy kind of thing that is non-medical, non-carceral.
Right.
That would be the place where, hands down, if you're not starting there, you're probably doing it wrong.
Right. Yeah, listening first and foremost. And also not becoming, it can be hard, but not getting heightened. If, let's say, I don't know, let's say that person does something. This is quite challenging, but let's say that person does something that the friend or parent or whoever doesn't like. If they react explosively, you've shut yourself out.
Mm-hmm.
And they're gone. They're not going to want to share with you anything. So you've lost that battle. It's rather than looking at it from the downstream effect, than looking at it from these are the outward symptoms. Where is it starting from? What's the core of what's going on? If somebody's doing drugs, for example, as in they're drinking alcohol or they're a heavy, not light cannabis. Light cannabis is not what I'm talking about. I'm talking about somebody's taking 150 milligrams of THC, like a lot. They're self-medicating. They're self-soothing themselves. But why? What's the reason why they are? And you get to that, not you have to stop drinking alcohol all the time. I mean, that's like understandable if that's really bad, but they can't just stop drinking alcohol, or they can't just stop taking whatever self-soothing medication without soothing the part that's happening, that's the catalyst that's bringing them to that point in the first place. And that's, that then you're going into biomechanics.
Which is also why a lot of psychopharmaceuticals are basically sedatives.
Mm-hmm.
They decrease our ability to feel, so that we cut off that what's the symptom and what's the kind of outward appearance of that thing.
Right.
I think as you build trust with folks. So there's I work also as like a peer mentor for people like in pretty extreme states. And so one of the things that can be hard to deal with, and I would imagine parents run into this frequently, friends run into this, they're going to understand that my loved one or friend is saying things that is not normal to them. They may be saying, in an instance that I have is I'll be working with somebody whose language, as it comes out, is extraordinarily violent.
Mm-hmm.
Language. If I were to act only on my gut instinct around like, whoa, cut off violence, I would be calling the police. This person would not be allowed in public, and I would forcibly contain them, because what's the potential that they could be violent? By actually listening to them, I know they are not a violent person. So what they are talking about in their violence is what they are experiencing on the internal. I know they will not act out this violence.
Mm-hmm.
If I don't allow them to talk in violent language, they're not going to actually express what they're feeling.
Mm-hmm.
So at a certain level too, we have to be willing to hear things that are abnormal, that are not going to be standard language for the person. They could come across like very racist.
Mm-hmm.
Who wouldn't use racist language if they only watch the news?
Mm-hmm.
We're bound to a world that is caught in extremes.
Right.
The extremes are violent, racist language. So if I'm not in a sort of consensus state and I'm moving through these kind of extremes, the only language we have to talk about extremes tends toward violent, racist language.
Mm-hmm.
Or God language. You can move into like extreme religiosity as another aspect of that. And so the only way to talk about it is through those extremes. So why wouldn't they use the extreme language?
Right.
So as somebody who's caring for it, I think you also have to be willing to back away and say, the loving person I know underneath the language is still there.
Mm-hmm.
They just need to get through this.
Mm-hmm.
I can be present for it. I don't have to agree with it. In fact, when I'm sitting with somebody who is talking very violently, I'll just repeat to them and I'll just say, wow, this thing that you're saying, that sounds really horrible to live with.
Mm-hmm.
I'm sorry that you have to like think that all the time.
Right.
That's very painful. I don't see it. That's not how I experience the world. But I can see why you would think that is very painful.
Right.
So I'm not validating it in a way that says everybody sees your viewpoint, but you do.
Right.
And I'm gonna make it real, and I'm gonna meet you there, and we'll talk through it.
Right.
And eventually, typically if I'm sitting with somebody, we'll go for a walk or something, like 2 hours of time. At the beginning, it's gonna be full on intense. I'll listen for a half hour before even saying anything sometimes.
Mm.
They just go. And then eventually they kind of realize I'm not saying anything.
Oh.
And they'll look sort of like, is everything okay? And I'm like, I'm just like, you have a lot to say. And this is, I can see this is painful for you.
That's really nice. Yeah.
So they've been listened to.
Yeah.
And then they introduce me to the conversation.
Yeah.
So it's not an unequal structure.
Yeah.
It's a place at which I can let them vent. I'm not judging them for the vent.
Yeah.
I'm going to meet them in the pain. By the end of the 2 hours, we've moved on to things like, how's your dog? Like,
Yeah.
like, let's talk about, and they get to the normal things.
Right.
And they realize that intensity, it actually isn't as intense as I meant. And it doesn't mean they won't go back to it. I mean, it's a daily cycle.
Right.
Well, for the most extreme, right? You go through these. But then they start to realize how to work with that language.
Mm-hmm.
And that ultimately that language doesn't hold power.
Mm.
The violent thing is just that internal angst and the things, the ways to express it. Turns out there's other ways, and I'm learning that in conversation.
Mm-hmm.
I'm not forcing it on them. They're not forcing their violent language on me. They're just sharing it.
Do you have to, when you're saying for that maybe 30 minutes or so of not just once about 30 minutes, maybe they realize that you've asked no questions. And you're just, do you have to pause yourself in that because you want to ask
yeah.
questions?
You
do.
Yeah.
Okay.
Yeah, it's like it's a it's a little bit of a test as well.
Yeah. Okay.
Because there's so many times where I want to jump in.
Yeah.
And because part of me is also just intrigued.
Right.
I want to ask questions, but I realize that I do need to slow myself because this isn't my place. I'm meeting them.
Yeah.
They're not coming to me.
Right.
In theory, yes, they
Sure.
are. But if we're talking about this sort of constructed space for them to talk, I'm coming to their world.
Yeah.
What I have to say is the least important thing.
Okay.
So it's more about listening. So yeah, I gotta cut myself off frequently.
Yeah.
And just pause.
So what you'll do, it'll be like, I have a question, and then you'll just be like, stop it, self.
Yep. Just let them talk.
Okay.
They'll get through it.
And then you wait. You will. Is it that you will wait?
I'll just wait.
Oh, interesting.
I mean, I'll do things of
Yeah, you'll give
They know I'm listening.
Yeah, you'll give those. Yeah.
Yeah. So they know I'm not disengaged.
Yeah. Take some notes, people. Whether it's your friend or
don't take notes in front of the person.
Yeah, don't take it in front of them.
Taking notes in front of the person actually can be a problem.
Okay.
Because then it's also like, are you spying on me?
I'm going to take notes about this.
I just wanted to clarify that.
Yeah.
That can also backfire if you're doing it in front of the person.
That makes sense. In the last interview, you were saying that a doctor had said you were making up your symptoms.
A psychiatrist.
A psychiatrist. Could you expand? I'm just interested in what that story is.
So I had been in the hospital. I can't remember how many days it was at that point. I think in total I was there a week and a half.
What year would this have been?
2013.
Oh, okay.
It's the last time I was in the hospital.
Wow.
This is the same visit in which I was assaulted, and it was miserable. One of the worst hospitalizations I've ever had. And the doctor came and said, I think you're faking your diagnosis. And the rationale that he had behind it was that his expertise, he had been in this field for a long time, made that very clear, that he has a long practice, and that everybody he has worked with schizophrenia cannot function, and that I am too high functioning to have that diagnosis. I was too deep in my own state to argue. I couldn't facilitate a response other than I do recall getting very upset and angry. And my response in these states is a complete shutdown.
Okay.
I don't respond. I just shut off. And that is a part of my extremity. I may have mentioned this last time. One of my symptoms at my most extreme is that I actually lose the ability to speak.
Oh, I had that. I've had that as well.
So
Hmm.
part of that, again, is like I can't argue with you because I'm also in this place of it's not going to make any sense
Mm-hmm.
if I start to anyway. But since then, and I've considered writing a letter to said
Mm-hmm.
doctor. I won't, just because it won't go anywhere. I have a feeling that he's just not the person who wants to listen.
Mm-hmm.
But since then, I have come to learn that there are a vast number of people with diagnoses, either identical to mine or tangentially, sort of peripherally the same, who are very high succeeding.
Hmm.
And in fact, it is a misnomer to assume that a diagnosis means lack of capability.
Mm-hmm.
In fact, I would say that it's probably like any. How many people are left-handed versus right-handed? Uh, I'll put it this way. My background is in visual arts, and I have studied madness in art pretty extensively.
Mm-hmm.
And in 1922, there was a book that came out called Artistry of the Mentally Ill by Hans Prinzhorn. And he was navigating like artists in the asylum, and he was pulling out artwork and trying to cultivate
Oh
it
yeah,
as like
you were talking about
this
this last time.
really important cultural aspect.
Mm-hmm.
It's led to both good and bad. That's a discussion for another time.
Mm-hmm.
In his book, um, he pulls out what he calls 10 schizophrenic masters, and he talks about their work. And then he does an interview. And in the interview, somebody asks him, I want to say the question was something around this notion of genius and artist,
Mm-hmm.
and that there must be so many artists in the asylum because mad people are by nature genius. And there's some level of that they're closest to sort of the human soul, the purity of the human soul. And so, like, there must be. And his response was, no. In fact, the number of people making artwork in the asylum is generally proportionate to the kind of general population.
Hmm.
The number of people who choose a career in art in the general population and the number of people who don't choose an art career
Mm-hmm.
is generally proportional to like an asylum
Hmm.
population. Again, this is the 1920s.
Mm-hmm.
So asylums were big business then.
Mm-hmm.
To me, that's sort of like, that should be obvious.
Mm-hmm.
That having a diagnosis does not pin you in any direction. You can be successful and you could be not successful.
Right.
You could be an artist, you could not be an artist.
Right.
You could sit and write 20,000 page books, you could not write anything.
Right.
It doesn't precede any idea of identity around you.
Mm-hmm.
And that's the problem. And I think that the doctor came to it with this assumption of the diagnosis is wrong because you don't fit my understanding of that diagnosis.
Right.
It was about him, his professional opinion.
Right.
So there was a lot of friction there that was deeply rooted in his perceptions and his lack of ability to understand my position.
Right.
As somebody who has extreme sort of states.
Right.
Yeah, I think that answers.
I think that answers it. Yeah. Yeah, and I mean, as somebody who grew up listening to doctors having accidentally left scissors in people and other things, and then the patient would come back and then get an X-ray, and then they would not show the patient the X-ray, and then take the scissors out, and then never talk about it again. I was very aware that they are just people.
They are. And they're people with opinions.
They're people with opinions.
And now, not to say that their professional opinion lacks
Right.
any credibility.
Right.
They've studied something.
Right.
But by having studied it does not make you the sole proprietor for all of understanding of
Right.
that situation. How many times do we hear women talking about the lack of the medical system to understand what it means to be a woman?
Right.
Where they'll be experiencing some sort of extreme physiological distress, and the doctor will just say, yeah, I think you're like, maybe it's your time of the month, or maybe you just have some depression, or, right? They just pin it on these like emotional distress kind of things without paying attention to the physical distress. So I think in so many aspects of our medical model, we presume the best of people.
Mm-hmm.
We presume that we are highly intelligent. We are brilliant human beings. So therefore, we must have the answer.
Mm-hmm.
The people who have the answer are the people who've studied it the longest.
Right.
Without understanding, we're basically toddlers with big toys.
Mm-hmm.
We get things right. We put the square peg in the square hole, but we also try to put the triangle in the square hole.
Right. You're mentioning the not being able to speak at points. I also experienced that, but I know sign language, and when I get like that, I can sign, and I can say, I'm scared or I'm sad, and I can still do that, which is interesting. But I could not speak.
I can physically write.
Yeah. Yeah.
I can write, but it takes me so much longer to write that nobody has patience.
Yes. Yeah. Yeah. Well, and not many people know sign language, so.
Yeah. So the
I
other
remember
thing,
there was a point where I was like, I had something had happened, and I was like on the ground, and somebody could come over, and I was signing to them, and they just thought I was deaf, but it was because I couldn't talk at the time. But I was like, man. Yeah. We're gonna say.
there's a terminology used in the disability advocacy world called crip time. And crip is like queer or mad, a term that was derogatory but reclaimed.
Oh, okay.
So in disability advocacy circles.
Oh, from cripple?
Yeah.
Oh.
Yeah. Okay. They use it now as a identifier.
Oh.
Somewhat satirically.
Like CRIP?
Yep.
Oh.
Yeah. So crip time is this notion of it takes people with disabilities longer to do things.
Oh.
And therefore we should be able to accommodate.
Yeah.
Seldom do we accommodate.
Like Italians. Ayo! Go on.
So that is a disability.
Yeah.
Being Italian.
Being Italian. Oh, man.
I have Italian heritage too.
That's
so this is
funny.
like, it's deeply rooted in my disability identity.
That's right.
So for example, somebody who has like different motor function,
yeah,
it will take them longer to get their shoes on. Therefore, it's going to take them longer to get to the bus.
Right.
And therefore, they might miss the bus because of all the extenuating circumstances. So what are we doing to accommodate crip time in our lives? And I bring this up because we're talking about this like inability to speak, or I have to write, or you have to sign, and that might take a longer. We have this presumption that we just need to like figure things out and move, that we forget that people's humanity sometimes moves slower. So if we are always trying to kind of meet people on our time, we're not authentically being present with them. And again, it comes to the comfort. Whose comfort am I assuaging? Am I trying to rush through this conversation because I want to get to the result?
Right.
Or am I going to be present for somebody? Let's go to the if I'm talking to somebody with violent language for that 2 hour and I'm with them. Am I just trying to get them through the violent language in order to reach some sort of result? So I'm like egging them on to get through it, which is not helpful.
Yep.
In fact, it can exacerbate the longevity of that experience. Or am I just going to let them do what they need to do for as long as they need to do it?
Right.
And for some folks, I mean, it can take years and years to do this. And I know we'll hear a lot of parents get frustrated by this, that they're working with their child or friends with their friends, and they're not seeing results. It comes up sometimes as I'm exhausted. And yeah, rightfully, probably so. If you're trying to force somebody into your paradigm, it is going to be exhausting as hell, and it's going to be a fight the entire way, very conflictual. So I wouldn't be surprised if somebody felt very exhausted in this. But we'll hear sometimes that in that exhaustion, they're looking for answers, and so they'll sometimes try to fake symptoms or exacerbate symptoms in how they talk about it in order to incarcerate somebody, to get them medicalized.
Exaggerate.
Yes.
Yeah.
They'll take that symptom and make it sound a little bit different in order for the person to be sent to an institution.
Yeah. But you mean exacerbate? You mean exaggerate? Or you could
exaggerate.
But you could also exacerbate it if you really got him into a panic state.
Well, I mean, it does, right? Because it decreases if I'm talking about you
Mm-hmm.
and you're hearing me, and I'm changing your experience,
I would be mad.
it would exacerbate the symptoms,
I would. Yeah.
right? And at that point, we've lost all trust. Again, we fall back into the same paradigm where we lose trust.
Right.
You decrease hope and the capacity for somebody to feel like they have community or family.
Right.
They suddenly are going to think very paranoid because everybody around them is changing their experience
Mm-hmm.
in order to put them somewhere.
Mm-hmm.
And they know it, whether or not they're verbalizing that fear in that regard. At some level, they do know
Mm-hmm.
what is happening around them. I'll work with people, and it will come up sometimes as they talk about a fear of being heard in public.
Mm-hmm.
So they have a paranoia around people overhearing their conversation.
Mm-hmm.
Ultimately, their conversations are boring. There's nothing to overhear.
Mm-hmm.
But when you step back and look at years and years and years of that person's history, the way that their languages have been distorted to put them into institutions,
Mm-hmm.
yeah,
Mm-hmm.
I wouldn't want anybody to know what I was saying because it's just twisted, used against me, and then I'm forced into a position. So I think that when we don't allow people the time it takes to develop their experience and talk about it,
Mm-hmm.
or we exaggerate and change their experience
Mm-hmm.
so that we control power and comfort, we've completely foregone any hope of what healing might look like for one individual.
Yeah. I want to. Do you want to say more?
No.
The last part. Well, should I tell a story about? I can tell a story about helping blind musicians, or I can tell you about the last part, which is a positive. Whichever one. I can always do that story later.
The deaf musician story?
Yeah, I could always do it later, or I could do it today. Whatever you want. Blind musicians.
Or blind? Let's do that. Let's hear the story.
You were saying about crypt time. I feel wrong even saying that. I don't think I can say it. Can I say that?
Yeah. Like anything, it would be
Oh,
language. It would be inappropriate if the language was not being used by the group affected by the language.
Okay.
Which is still different than something like using the N-word, right? They're using it to in power.
But I'm using. If I just said that, it's
I know. I'm just saying it's a little different than like the N-word,
oh yeah,
which
sure.
still holds power dynamic.
Okay.
When we talk about crypt time, especially when we're using it in this kind of conversation, we're using it as an empowering tool to empower that experience.
Okay.
Does that make sense?
Understood.
So
Well,
in this context, yes, absolutely,
Sure.
use it.
okay. Well, so I was out after show. My buddy Tommy, he's a great drummer.
Oh,
You know Tommy?
I know Tommy.
Oh, you know Tommy?
Yeah.
He's great. All right. Well, then you're gonna be extra interested in this
Okay.
story. So it's Tommy's show. He was just performing over at the pottery place, and he had a great show. And afterwards, he's super pumped. His mom was there. His girlfriend's there. His friends are there. He was playing with his buddy who was also blind. He was playing guitar, and he's packing up his drums. And he had taken the toms off, and when you take a tom off, there's a little metal rod that it goes into, and you put you hook it in, and unfortunately, he went like, because he's blind, he's got 2 glass eyes. He went like this, and then had this blood curdling scream because he had jammed his glass eye into the metal spike essentially. And he's bleeding now. And he's holding his face, understandably. He's like in pain. And it was probably only 10 people there at that point. Most of the audience had left. And we're all silent. And just trying to visually see what has happened and give him a moment. He then settles down, and his mom is like, comes over to him and is like, "What's going on, honey?" And he explains what happened, and she goes, "Let me see." And he's like, "No, no, no," and let me see. And he goes, "Okay." And there's blood coming down, and then she checks his eye, and he's clearly it's not. He's like, "It's okay, it's okay. It'll be all right." So, but he's in pain,
Yeah.
and he's like, I can't tear my drums down. I have to get it tomorrow. Because nobody knows how to tear drums down. And I was like, I know how to tear drums down. And Tommy was like, oh, all right. And so he sits down. His mom and girlfriend are taking care of him. I'm tearing the drums down. I got my van, so I say, I'll just pack it in my van. We can just drive it over. So we move all the gear in, and we start loading it back at his place. And this is the part. I mean, of course, everything's taking longer in part because drums take forever anyway. But as we're going through the gate and we're going through this courtyard, suddenly I hear this like it sounded like this. No wait, without the metal though. It was like a clunk. And suddenly I hear the guitar player's girlfriend go, "Oh!" And I went, "Oh my God!" And she had hit a tree. She had like walked into a tree. And I was freaking out. I go, "Oh my God!" And then they go, all three of them go, "Oh yeah, tree." That's it. And then she keeps going. And then I'm like, "Are you okay?" And she goes, "Yeah, it happens all the time." I went, "It happens all the time?" And then all three of them go, "Yeah." And it really made me realize the difference in reality. That if I hit a tree like that, I would be I don't think I could just walk it off and then go back inside. I would be like, "Oh my God." I'd be freaking out about it. But they happen so often to them that they're just like, "Yeah, yeah." They didn't even care. They can't see what happened to her. They heard it, but they're just like, "Yeah, tree." And then I'm going into the place. It takes time to get in because drums. But then we're going in. Everything's black. I can't see anything. And I'm like, I didn't want to say anything. So I'm just in there trying to load drums in pure black. And I'm just like, and Tommy's like, "You want to hang out?" And I had to get going, but I was like, "No, it's all right." But I was thinking, I can't see anything. And I was like, this makes sense. And I had to then go into I didn't shift and say, "We need some lights." I just was like, kind of you saying, going into their, shifting the paradigm. I was just like, this is how they live. And I'm going to be in pure darkness right now, just loading drums. And I can't see anything, but he's going to tell me where it is. And then I can't see. And then I'm moving it around and they're helping me. And then I was like, I put it down and I said, "All right, I'll get going." And anyway, that was that night. But was showing that, I mean, things can take longer.
Mm-hmm.
But I think more importantly is that their reality is still their reality. It's totally different how somebody else would have responded to hitting a tree with their forehead. So,
And we see this, I think, disabled folks will have horror stories around. They'll be eating and just somebody will come up and start feeding them.
huh?
Oh, this happens. Yeah, there's really bizarre things that start to happen.
I don't even know what you mean.
Because we see somebody and we see that they have a disability and that they're moving slower.
Yeah.
And we think they need help. And I can be the one to help. We're not allowing them the time they need to fully experience their humanity. And we rush in because we are discomforted by watching them.
Oh my God.
And so to assuage our discomfort, we come in as the heroic.
I'd be so mad.
Oh, yeah. Oh, yeah.
Oh, I didn't even think
The
about
horror
that.
stories are there was a funny, this last Halloween, we did a Crip Halloween. And one of the elements of the Halloween was spooky stories.
Okay.
And they were all access stories.
Access stories.
Access, like disability access. Like I didn't have access
Oh.
to things, and so then somebody jumped into this horrible thing. So they're like scary stories,
Oh my God.
but the scary stories were true stories about how they've been treated in the world.
I feel like that'd be a good.
It's the satire of it is hilarious.
That'd be a good special.
Um, and so it's the kind of thing that happens frequently. But the point of all of that is to say, we don't often allow people the time it takes to live their life on their terms
Right.
because of our discomfort.
Yeah. And do you want to say any more to that? The last thing to wrap this up is about the myelin sheath. You know what I'm talking about? The myelin sheath is a part of a neuron. It's what helps conductivity. So it's like a fatty outer layer, kind of like a microphone cable or any cable. And if it's a healthier myelin sheath, the neurons will fire faster. Antipsychotics can degrade the myelin sheath. It's part of why gray matter it can become smaller on antipsychotics, and the basal ganglia can become damaged from antipsychotics, which is in part related to the myelin sheath. Now, the exciting news is that remyelination can occur. So cardiovascular exercise can actually cause remyelination. And Hannah with multiple sclerosis is an incredible example of that. I mean, she's fighting against demyelination all the time she's working out 5 days a week and eating wildly healthy, and mitigating many really bad symptoms through doing that. But essentially, the issues that you got from the medications is possible to circumvent through specific protocols that can cause an increase in brain-derived neurotrophic factor, other healthy brain chemicals. That would be through whether it be contrast therapy, which would be cold showers or a nice bath. I prefer cold showers. It's just easier and cheaper. Or cardiovascular exercise, resistance training also does it. And then also the other things that we had talked about the last time, those all contribute to remyelination. And remyelination takes about on average, 6 to 12 months. Of course, if somebody is compounding more things, it could be faster. If there's less things, it could be slower. And of course, everyone's also unique and different in their chemistry. But an average of 6 to 12 months for remyelination. So it was exciting to see that. I was like, oh, cool. So it just know that it is a possibility of healing the basal ganglia and those other parts of the brain, but it takes time.
I had one last thought.
Yeah.
As you were going through that. And I think it encapsulates a lot of what we've been talking about through this is I'm part of a cohort of people doing like some trainings and things. And one of the things we had to write a story of something that happened to us that helped us in sort of our disability identity. And one of the things was I had been filming down at Fullerton Beach with some art stuff. Nothing fancy. I'm coming back to the train. This woman's walking her dog, and she stops and is like, "Are you a filmmaker?" I was like, "No, I'm not. It's for art. Like, it's not for film. It's for like art pieces." And she goes, "Oh, what's your art about?" And I explained that my artwork deals with my lived experiences, knowing that most people don't know madness. And at the time, I was using a lot more medical language, so I was like, "Oh, I make work about my relationship to schizoaffective disorder." "Oh, what's that?" I was like, "Well, it's schizophrenia, depression." She kind of looked at me and just said, "Your medication must be working so well for you." At which I'm not that shy about it. And I was just like, "I haven't taken medication for 10 years. And she said, "Oh, and then got her dog and like walked off.
Uh-huh.
Um, so there's like this frustrating circumstance. But what I wanted to bring up kind of at the end of all of this is to say, you never know how somebody is experiencing their diagnosis or their madness.
Right.
It is unfair to presume anything about either end if you're going the medical route or you're going the mad route. We should never make presumptions. I think, for example, for most intents and purposes, I appear very normal.
Mm-hmm.
I conduct very normal. But I don't think that would be fair to my experience because I live in some very, very different places in my head
Mm-hmm.
that don't make it to public because I know what will happen to me in the public.
Mm-hmm.
So to presume that I am normal or that the doctor presuming that I couldn't function, I think it is unfair to folks to. So let's say you're listening to this conversation or the previous one, and you're like, I hope my kid someday can be as eloquent as Matt is speaking about his diagnosis. Bullshit. That's off the table. They should be as eloquent as they are, and you should meet them on their terms. I also want to let folks know that while there might be an appearance of some normalcy, I live in some really odd places myself, and it is a battle every day.
Mm-hmm.
I carry it differently than others, but that is not to presume I live without it,
Mm-hmm.
or that somehow I live a quote unquote normal life.
Right.
I live in different places. I live in different times, and that is something I am happy to come to terms with. And that can be a discussion for another time. But I wanted to leave kind of with that note of I hope that as they're asking questions about my experiences, that it doesn't come to a place of using me then as a barometer
Right.
for other people's experience. That should not be the case, other than just to like share a little bit of what some paths can look like.
Right. And thanks for adding that. The last part is you can, if you have questions or comments, there will be a link in the description for many different things. So just look in the description, you'll find a bunch of links. There'll be a link for the Center for Mad Culture. And yeah, check out all those links. There's many resources for you. And until next time.